Morning to all of you, students. Hope you are all doing well. I think shortly you will be coming for direct contact classes also in another 2 or 3 days. The circular may come to you. But take care of yourself at any given point of time. Today, I want to tell you something about the liver diseases, particularly focusing on chronic liver disease, cirrhosis of liver, which is often asked in the theory and also in practicals also. You will get as a long case or short case also. Simple questions only. They are asking you, the examiners, they ask always simple questions only. Just you have to think and tell. Proper answer, common answers you have to tell. So liver has got enormous blood supply when compared to other organs. It has got a dual supply in the form of portal vein and hepatic artery proper. As all of you know, the hepatic artery is a branch of celiac axis which arises from the anterior part of the abdominal aorta. It brings oxygenated blood. Portal vein drains the intestinal tract right from the lower end of esophagus up to rectum and anal canal in the form of superior mesenteric vein and inferior mesenteric vein. A separate vein is there which arises from the spleen, which is called splenic vein, which joins with the superior mesenteric vein. They are not there in the slides. Just I am telling the basics of this blood supply, etc. So splenic vein joins with the superior mesenteric vein to form portal vein. Inferior mesenteric vein is nothing but the continuation of superior hemorrhoidal vein. Actually, it's not presented here. It joins the splenic vein. The superior hemorrhoidal vein has got connection with it's single unpaired. It has got connection with the anastomosis with the middle and inferior hemorrhoidal veins. The middle and inferior hemorrhoidal veins, they are tributaries of internal iliac vein. As all of you know that internal iliac vein joins with external iliac vein to form common iliac vein. Both will join to form inferior vena cava. So there is a connection between this portal system and tributaries of systemic venous system at the level of rectum and anal canal. So superior hemorrhoidal vein continues as a inferior mesenteric vein which joins the splenic vein. Splenic vein joins with superior mesenteric vein to form portal vein, which divides into two divisions and ends in the liver, into the hepatic sinusoids, into which hepatic artery blood also is flowing. After processing of this blood, it is drained in the form of central vein and then into hepatic vein. Two or three hepatic veins are there. They go and enter into this inferior vena cava, which is going behind the liver. Inferior vena cava ends in the right atrium, into which superior vena cava is also entering. Often I will be telling all these points. If you remember basics, you can tell some other answers also. How is the superior vena cava is formed? It is formed by two brachiocephalic veins. In turn, brachiocephalic veins too, they are formed by the vein of subclavian vein and the interjugular vein. So, interjugular vein is important to see the pulsations and also the failure and also for the stitch procedure also. Transjugular intrahepatic porta cable stent shunting procedure which we do to reduce portal pressure. Here we select right interjugular vein and we pass a guide wire into the brachiocephalic vein and then into the superior vena cava into the right atrium. Like that to pass, you have to negotiate with the inferior vena cava. That's why this venous system, venous drainage and the vascular system of the liver is very much important. Commonly, the patient in the cirrhosis of liver, it comes with the distension of urine. Causes being again various causes are there. The pre-hepatic, hepatic, and post-hepatic causes are there. Commonest cause being either in India or some other area also. 60 to 70% of cases being alcohol in origin only. Alcohol consumption produces cirrhosis of liver. Other very common cause being viral hepatitis, particularly hepatitis B and C virus. The other uncommon causes are there, but we have to tell either in theory part or practice also if you are asked to do that. Storage disorders, hemochromatosis, Wilson disease, they are all other common causes other than alcohol and hepatitis B virus. which are being very common causes. Distension of abdomen, we focus mainly in the exam hall also we focus mainly on the distension of abdomen only. Is it not? Which is due to fluid collection or an organomegaly. These are other than physiological causes like fat, fetus, feces like that. There are other physical causes. But other than that, pathological cause being collection of fluid, which you call it as ascites. It's a very common cause. Even a big liver also can occupy the entire abdomen. A big spleen can occupy the entire abdomen. Is it not? Distended urinary bladder, enormously distended urinary bladder above umbilicus, it can also occupy the abdomen. A big ovarian cyst tumor, a big fibroid from the uterus, they also can occupy the entire abdomen. The lymph node mass, in case lymphomas, like that, the distension can be due to an organomegaly or a tumor mass or fluid collection or dynamic or aerodynamic neuralgic ileus, where the intestines, walls of intestines, they get paralyzed and fluid collection will be there, gaseous distension will be there in the abdomen. That also can put the distension abdomen. So, causes of distension abdomen means you have to enumerate all these. So, organs enlargement, tumor neuralgic ileus. So, all these causes you have to enumerate. One such common cause being cardiac failure, which can produce enormous distension abdomen. Cardiac cirrhosis also is there one condition. They are all back pressure will be there. Cardiac failure means any chamber will fail, either the left atrium in the form of, in case of mitral stenosis, mitral regurgitation, left atrium can fail. And right heart also fails, where distension of veins will be there, inferior superior where it will be depicted as a JEP. The back pressure will be there into the liver, and the portal venous hypertension also will be there. Like that, fluid collection will be there in the peritoneal cavity due to congestive cardiac failure. In our case, the liver disease, where due to disease pattern, either due to virus or due to alcohol, there will be extensive fibrosis in the liver parenchyma, which obstructs the blood flow in the liver parenchyma. Thereby, this portal venous blood will be impeded, portal venous pressure will be there. Increased pressure will result in the collection of fluid in the peritoneal cavity. So, this is a other reason being collection of fluid in peritoneal cavity due to portal hypertension due to cirrhosis of liver. So one cause is cardiac cause, other cause being the liver cause. You have to tell that directly you cannot pinpointedly tell only one cause. This is a distant abdomen due to ascites, this is due to liver disease. You cannot pinpoint. You 2-3 diagnoses also you can keep. Other than this, a patient comes to you with history of long-standing low-grade fever, evening regular temperature, with or without cough. One can suspect with this distant abdomen tuberculosis peritonitis also, which is very common in the Indian setup. So common causes being either a cardiac failure or a liver failure or a tuberculosis peritonitis. So these three you have to keep in the examination common points you have to tell in the exam hall, which can produce distant abdomen. Common complications also you have to tell in the examination. So, if patient comes to you with history of distant abdomen means you have to tell the liver problem or cardiac problem or tuberculosis peritonitis, common causes. Similarly, patient can come with history of hematemesis, for example. You have to tell commonest cause being varices, especially varices. They can come with history of hematemesis. Common cause of hematemesis being upper GI bleed. Common cause that also is given in the question. See, apart from the old age people, malignancy or suspect. In case of young people, particularly in case of cirrhosis of liver, lower esophagus, where varices will be there, they bleed. This will varices bleed. When question is asked, what is the common cause for this hematemesis? Our people they say that this is cirrhosis of liver, then the third this is portal hypertension. You have to tell pinpointedly the answer that this is varicose bleeding, this is varicose bleeding from lower esophagus, which is due to portal hypertension, which is due to cirrhosis of liver. Like that, you have to tell answer also. So bleeding for rectum can be there. Bleeding for rectum is due to that hemorrhoid bleed, which I told you already. There is junction of portal venous tributaries with the systemic venous tributaries, that is hematochezia, which we see. Or if more blood is there in the stomach due to massive esophageal varicose bleed, there will be rapid intestinal transit, colonic transit. The same upper GI bleed can present in form of lower GI bleed also. Patient can come to you with altered sensorium. So one is hematemesis, number 2 is hematochezia or bleeding for rectum, number 3 altered sensorium. Altered sensorium again it is due to hepatic encephalopathy. This is due to liver cell failure. Commonest person asked is what is the clinical or bedside test you want to do in hepatic encephalopathy? That is nothing but lap tremor, demonstration of lap tremor, that is called asphyxis. One common cause being liver disease, the other common cause being even the chronic respiratory failure also one can demonstrate asphyxis. So these two are common clinical conditions where asphyxis is seen. The clinical features from above downwards, which you see in liver cell failure, they are upstairs dry and downstairs fullness will be there. Clinical features upstairs complete dry, dryness of the almost emaciation in the upstairs head and neck region and upper part of chest. It is there will not be an edema. Downstairs it is full due to edema in the lower limbs, entire lower limbs and abdomen distance is there. The middle part and lower part is full, upper part is empty. Then spider nevi and gynecomastia they are important. They are asking commonly. In males we see gynecomastia. In case of females there will be atrophy of the breast will be there. Commonly in males impotence is one clinical feature. Apart from that we have the testicular atrophy also. It is important finding. They are asking clinically how do you examine for testicular atrophy means you have to see the feeling of empty bag. That is you cannot feel palpate the scrotum in the testis in this scrotal sac. That's the what the answer you have to tell. How do you examine the testicular atrophy means if you palpate the scrotal sac, you cannot appreciate the testicular substance. So patient will have impotence and testicular atrophy, both will be there. And loss of hair will be there. Axillary hair, pubic hair also will be there. There are some pictures are there. How do you examine for the jaundice? By actually for anemia, you have to pull the lower eyelid downwards. For jaundice, you have to see the upper eyelid upwards to see the sclera. Commonly, they are asking in a short case if you are given how to demonstrate for pallor or anemia or jaundice, they are asking. And other features as we are continuing, one is spider nevi. Spider nevi, with your bare eyes also you can see, but here the hand lens is used to see the central arteriole, dilated or branching arterioles. You have to apply some pressure at the central part so that branching will be there. If you release the pressure again, it reappears. Commonly seen over the chest and frontal chest and back of chest and the head and neck region. Commonly, this is spider nevi. Then something here which is pressed on the palmar aspect with the thumb. That is related to the palmar erythema, which is commonly seen in fair skin people in case of cirrhosis of liver. If you apply pressure, there will parallel there again it and the flushing will be there. Clubbing also is not so common, but it has to be examined. Clubbing, liver cause of clubbing, then lung cause of clubbing, and the cardiac cause of clubbing, GAT cause of clubbing also you have to enumerate. Exams on liver and spleen, they are important. Common question asked is how do you assess the liver span? Simple question they are asking. Examination of upper part of liver, examination of lower part of liver. That means nothing but those 2 points only. Upper part of liver, how do you assess? By percussing from above downwards in the right midclavicular line from right second space or right second intercostal space onwards. If you percuss from above downwards, you will appreciate the resonant note in the second, third, and fourth also. Sometimes fourth intercostal space on right side, you may get the impaired note that you can take, but definitely will get the dull note in the right fifth intercostal space, which you have to take it as a upper part of liver. In impaired note also you can tell, but most of the times they take it as fifth intercostal space on right side, right midclavicular line, the upper part of liver. To approach the lower border, 2 methods are there. One, you have to palpate from right iliac fossa to right hypochondrium. The next method being percussion also. In same fashion, if lot of fluid is there, percussion method may not be useful. If less fluid is there or fluid is not there, then you can percuss from the right iliac fossa to right hypochondrium. Therefore, you can appreciate the lower water of liver. But mark it and you have to measure it in centimeters. Normal being 10 to 12 centimeters with the liver span. Commonest question asked is how do you examine the liver span? And the liver markers also they are asking, not liver markers, bony landmarks of liver, bony landmarks of pleura, bony landmarks of lung also they are asking. Spleen, commonly you are asked how do you palpate spleen and exact method of examination in the supine position. You have to go from the right iliac fossa to left hypochondrium. Thereby, you can appreciate the border of the spleen. Whether it is mild, moderate, or massive enlargement, you have to tell clinically. If notch is there, you have to demonstrate. And you have to differentiate between the splenic swelling from the renal swelling also clinically. If you cannot appreciate the splenic swelling, you have to turn the person into right lateral position and you have to press this left lower chest towards you, and again you have to palpate in the right lateral position. Percussion method also is there. If they ask you, you have to percuss in the left middiagular line from above downwards, and you have to appreciate the dull note. Whether 7th space on left side or 8th space, if it is dull, you can tell the patient is having a spleen. By that time, the spleen is not palpable per abdomen, but it enlarges upwards and then towards the right iliac fossa. Therefore, percussion method in early stages of splenomegaly is useful. Normal weight of spleen is 150 grams. Ascites, so you are supposed to examine the findings which you have to tell whether fluid is there in the free fluid or locate fluid is there in the peritoneal cavity, and demonstration of edema and demonstration of atrophy of the this also. Sometimes some exams are asking here sacral area also they are examining for edema. In lying down position, most of the times the edema will go into sacral area. And lower limbs, just above the medial malleolus, you have to apply pressure for examination of edema. In case of either liver failure or renal failure or cardiac failure, you have to examine in these 2 areas. One is sacral area, and the one is just above the medial malleolus. You have to check for the edema. Here they are showing ascites how to examine. But again, 2-3 points I will tell now only. These are some clinical appearance in case of cirrhosis of liver from above downwards. All these points again and again will repeat 1 or 2 classes in future also. This all already have told. Caput is one important point where there is a dilatation of the veins around the umbilicus in all directions. The veins in the upper area of the umbilicus they go towards the supravenical area. The veins below the umbilicus they go towards the inferior tributaries. Common question asked is how do you say the veins they are carrying blood? How do you know in which direction? What is direction of flow in case of supravenical obstruction, inferior venical obstruction, and portal hypertension? Three pictures you have to keep in your mind. When supravenical obstruction is there, the venous blood flow will be from above downwards. Simple point to remember. Because supravenical obstruction, the venous blood flow will be from above downwards and towards the umbilicus, and also towards the inferior venical tributaries in the veins away from the umbilicus. Some veins will be there, dilated veins. In case of inferior venical obstruction, the venous flow will be from below upwards, that towards the supravenical tributaries. In case of portal hypertension, the blood flow will be away from the umbilicus. These 3 points definitely you have to remember and tell. So here again, coming back to this fluid shifting dullness, I'll tell few points. When the fluid is more than 1500 ml, less than 1500 ml also carefully you can assess for the shifting of fluid. But with more than 1500 ml, we can happily demonstrate the shifting dullness. For that, from above downwards, you have to percuss from the ixiphysis sternum to pubic symphysis. You have to percuss from in the abdomen in the midline. While doing so, the coils of intestine, because of fluid, the presence of fluid, they are pushed upwards to the diaphragm. Is it not? When the coils of intestines they are pushed upwards, naturally we will get a tympanic note or hypertonic note in the upper part of the abdomen between the ixiphysis sternum and umbilicus. If you go down below the umbilicus also, continuously you have to percuss towards pubic symphysis. Then you will get the dull note because of the presence of fluid in the lower part of the abdomen. This fluid, if it is less, that will there in the only pelvic cavity. If more fluid is there, they will go into the paravertebral gutter also in either sides. Now again, you have to come upwards towards the umbilicus, where hitherto we have observed tympanic note or hypertonic note. There you have to turn your finger in the midline, so that you have to percuss to your side to see the change in the percussion note, whether the fluid is there in the paravertebral gutter or not. You have to percuss to your side. While doing so, definitely you will you will appreciate the change in percussion note from the hypertonic to dull note on your side, towards your side, away from the umbilicus. Then you have to turn the person towards the left side. First you have to percuss towards your side, means it is towards right side. Then turn the person to left side or to opposite side, so that this fluid will go to other side. And keep some time, either it is 30 seconds or 1 minute, we tell usually. But if thin fluid is there, it will go very rapid to other side. If thick fluid or pus is there, it takes long time, is it not? So that 30 seconds to 1 minute you have to keep time. But if percuss again, the coils of intestine, they will come underneath your finger. Either to they will be change in the note will be there. But you will appreciate the hypertonic or tympanic note. Now again, don't leave your finger, and again you have to go to left side while crossing the abdomen. Again you will appreciate the dull note. Previously you have heard the tympanic note or hypertonic note. Now you will appreciate just at the umbilicus level or the other left lumbar region. You will appreciate the dull note. Again, one more time you have to turn to your side. Like that, 2-3 times you have to turn to see whether the patient is having free fluid or locked fluid. That's the importance you have to arrive. If free fluid is there, anyhow it will change this side and that side. If locked fluid is there, that if it is more fluid is there, you will get fluid filled, and you may not appreciate the shifting dullness. So immediately you have to tell the patient is having ascites, sir. Shifting dullness is possible. Patient is having free fluid. Or if tense ascites is there, you have to tell the patient is having tense ascites. Fluid fill is there. Shifting dullness is not possible, sir. Organomegaly also, I could not appreciate. Rapidly the answer they have to come like this in flow. If moderate amount of fluid is there, you can tell shifting dullness is present, and the fluid fill is not there. And organomegaly, even if there is a little bit more fluid, also you can appreciate by dipping method. I think you are able to understand. Organomegaly, you can appreciate if moderate fluid is there, the more than moderate fluid also. In case of dense ascites, you cannot appreciate the organomegaly, you cannot perform the shifting dullness, and you have to appreciate only the fluid fill. There are some clinical features which are due to hepatocellular failure, dysfunction of the liver cell, and mechanical pressure in the liver parenchyma due to fibrosis in the liver parenchyma, which produces portal venous hypertension. They are all there. The common cause being the classified, I told you already. Pre-hepatic, intrahepatic, and post-hepatic causes. Where is the pre-hepatic area? It is just before the entry into the liver parenchyma. That's porta hepatis is there, is it not? To which the portal will be going by the hepatic artery is going, and the bile duct is coming out. That area is called pre-hepatic area. And portal will block itself without involvement of liver parenchyma. One can get portal hypertension. Intrahepatic means in the liver parenchyma. Just because of either alcoholic etiology or hepatitis B virus or some other drug, etc., they can produce intrahepatic parenchyma distortion, resulting in portal hypertension. Post-hepatic area means that is where the hepatic veins are joining the inferior cava, and the inferior problems like a Burchard syndrome or hepatic venous web in the inferior cava, or right heart failure, or congestive cardiac failure, or pericarditis, constrict pericarditis. They are all causes which can present for post-hepatic causes of portal hypertension. But if you know the vascular anatomy right from the heart through liver into the portal vein into the GI tract, because entire GI tract is drained by portal vein into the liver, and the liver is after the processing of blood, it is going into the through hepatic inferior cava into the right atrium. Like that, the cardiac causes, inferior causes, hepatic veins, parenchyma of the liver, portal vein, GI mucosa. Up to that, you have to keep in your mind to say any complications. GI mucosa also will be swollen in case of portal hypertension, either due to any etiology. The same picture is seen with portal hypertension or congestive cardiac failure also. The patient will be having all GI disturbances. Nausea, vomiting, distress, food, loss of appetite, everything will be there in case of portal hypertension due to liver pathology or congestive cardiac failure due to cardiac pathology, resulting congestive cardiac failure. These two cases, all GI symptoms will be there. Same will be there with digoxin toxic also, where the first sign or symptom of digoxin toxic is nausea, vomiting, loss of appetite, distress, food. All this will be there with even pancreatic problem also. So it is all liver is the cornerstone or central point for all this process. Our teacher used to tell Dr. Ramdas sir, if God appears before you and asks only one organ you want to select, means sir was telling liver you have to ask, not brain or kidney, because if liver is not there, you cannot enjoy life. That you can remember. Some important tests we will see. Some important tests means commonly asked in the examination. Any case, any patient, it is better to over investigate the case than under investigating the patient. Any patient you have to start from simple investigation, because India is a poor country. You have to start from simple investigations onwards, and next to the special investigation you have to go up to liver biopsy. Liver biopsy is the topmost investigation where it will come from the disease that I told in the initial step itself. Hemoglobin they will ask you. If today hemoglobin is 12 grams, tomorrow you came to 6 grams, means you have to tell that patient is having a acute upper GI bleed due to varicose bleeding. Like that, you have to tell. If total count is 24,000, means you have to tell the Vandian bacterial peritonitis or some other infection in the abdomen of this ascitic fluid. ESR 100 is there, we have to suspect tuberculosis or malignancy. We have translative ascites, exudative ascites, hemorrhagic ascites, chylous ascites. All variants also we have to tell in the examination. In next class, I may have to touch all those. The patient is 80 years old, he came with distance abdomen, running down weight. We have to suspect hemorrhagic ascites to malignancy. History of trauma, tuberculosis can produce chylous ascites also. So the ascitic fluid analysis is important for all the gram chain, AFB, then fungal filaments, then malignant cells, then amylase, even the tuberculosis, the PCR, adenosine is ADA. Any test you have to ask with the ascitic fluid. In total fluid also you have to ask all these tests. Bronchoalveolar lavage washings also you have to ask all these tests. This is simultaneously I am telling comparatively. So liver function is mainly the serum bilirubin, SGPT, SGOT, and alkaline phosphatase. These commonly they are asking what is the importance of unconjugated bilirubin, what is the importance of conjugated bilirubin, what type of elevation of bilirubin will be there in case of obstructive liver disease. Which is in the case of a patient is 90 years old, 80 years old, he comes with elevated serum bilirubin due to CA, head of the pancreas, periapital malignancy. The conjugate bilirubin will be elevated, is it not? Because of hemolytic jaundice, unconjugated bilirubin will be elevated. Like that, we have to tell important one point immediately. What are the tumor markers also they are asking. Hepatitis B virus viral markers they are asking because the common cause being hepatitis B virus. HBS AG, anti-HBS, HCV, and anti-HCV, HBeAg, anti-HBe. They are not given here, but you have to tell in the examination or in the report also. What are the contraindications of liver biopsy? Commonly asked question. So bleeding disorders mainly, a hemangioma in the liver, hydrated cyst. These three common bleeding disorders. Hemangioma means this is nothing but bunch of blood vessels, tumor of bunch of blood vessels. If you rupture it, it will lead to death. Hydrated cyst means if it is ruptured means you'll die with acute anaphylactic reaction. So soiling of peritoneal cavity will be there. You will die with anaphylaxis. Bleeding disorders it is contraindicated. So next time much more points will enlighten you, or meanwhile I think you may have to come to direct class also depending on the instructions given to you. So edema is there, ascites and edema feet if they are there, cause may be anything, but usually you have to give a diuretic therapy, low salt diet. Non-pharmaceutical management is important in any disease, non-pharmaceutical management of any disease. Because edema is there, you have to give loop diuretics like furosemide first initially. And the potassium sparing diuretics like spironolactone varying from 100 milligrams to 400 milligrams, you have to give. With the renin-angiotensin system, everything also they are asking. Diuretic therapy when it is there, you have to tell the diuretics which act at various segments of nephron. Tips procedure also I have told already. So if hypoalbuminemia is there, you may have to give human albumin or hemoglobin is also low along with the serum proteins. You have to give fresh blood also. If bleeding is there, you have to give fresh blood. Hypoalbuminemia also, if hemoglobin is low due to chronic bleed, you have to give fresh blood transfusions depending on the need. For this varicose bleeding, there some medical management is there, like beta blockers, like non-selective beta blockers, like propranolol mainly, and commonly octreotide or somatostatin like that drugs we are using. But otherwise, the bleed is there continuously. If you have to go for some intervention like spirotherapy, banding, and if continuation is there, you may have to go for surgery. But nowadays, we are not doing in surgery. Previously, they used to go for removal of the lower end of the with the upper fundal region and end-to-end anastomosis. But that type of surgery we are not doing now. So beta blockers, then octreotide, somatostatin is they are sufficient medical management. For some procedures means you have to go for spirotherapy or banding of the varices. So we'll meet next time. God bless you all.